A very good evening, everybody. I'm Dr. Alapi Prajapati, and I'm one of the members of WCMH West Zone IPS Committee. And actually, we are waiting for Dr. Ritamra ma'am to join us today. But I'm trying to contact her, but I'm not able to do so. So I think for the time will not allow us to wait. So I think we should start now. So I would like to welcome you all to join us join with us in today's webinar of Women's and Children Mental Health Subcommittee of West Zone IPS. I would like to welcome Dr. Sudhir Bhave, sir, who is the president of West Zone IPS. Sir, welcome. I would like to welcome you, sir. So as part of this, I think sir is not there. So as a part of this subcommittee, we arrange one webinar every third Friday of every month. Alternatively, one for child and one in the field of women's mental health. This month, we have this webinar in the field of child and adolescents mental health. Today's topic is very interesting, I think. It is OCD and its allies, navigating through the pediatric population. So it is a very interesting conversation, I think, because when we talk about childhood OCD, it is rarely a lone traveler. Most of the time, it will have its own entourage, like anxiety disorder, tic disorder, mood disorder, even sometimes post-infectious presentations like pandas. All these comorbidities, most of the times they might mimic OCD. Sometimes even they might mask the symptoms of OCD. More often, even they might magnify the symptoms of OCD. So it becomes very challenging for us to manage these patients, to identify these comorbidities. And even just labeling these conditions is not enough, because it is when our work starts, because tailoring our treatment and management for this patient becomes more challenging for us. The interplay between neurobiology and even psychosocial factors that shape this young mind's journey make this journey even more difficult. So today we are going to discuss and converse on this topic, and for this we have with us the, I would say, the most renowned child psychiatrist, Dr. Isha Sharma ma'am, who is associate professor in NIMHANS. And personally for me, it is I feel I'm fortunate enough to be moderator today, because I have always looked upon her and she is my inspiration. So I welcome you, ma'am, for this webinar. And I'm very sure that we are going to have this interesting conversation, and we are going to learn a lot, many things from you. Ma'am hardly needs any formal introduction, I would say, because we all know her. She has many awards on her name during maybe as young psychiatrist, or even the most promising outgoing resident doctor. Also, she has numerous book chapters on her name, publications, and even she has been the part of national guidelines in the field of child mental health. So I welcome you, ma'am, for today's webinar.
Hi, thank you, Dr. Alapi. This is a very, very generous introduction, and I will try my best to live up to it. So, I'm gonna just I think you'll have to stop screen sharing so that I can share.
Yes.
Yeah. Okay. So what I thought, one is I particularly chose, this topic where, we could discuss about OCD and, the kind of mixed and very comorbid presentations that we, often see in young people for all the reasons that and Dr. Alape just listed, that it's, comorbidities are, more of a rule than an exception. Comorbidities is something that, can really interfere with identifying OCD, planning treatment for OCD. It also has a deterministic role in, what long-term outcomes are going to look like for in a given person. So for these very many reasons, I thought if you're talking about OCD, if you're talking about childhood OCD, then comorbidities is something that, we could focus on for today's session. So with that, let me begin with this particular slide. So this is from the systematic review and meta-analysis that we did a few years ago, where the question that we were asking is, what is the lifespan pattern of comorbidities that, one could see in OCD? So if you pull together all the studies that have recorded comorbidities in, samples from children, adolescents, and adults, then what are the kinds of comorbidities that stand out? Do they change or remain the same over the lifetime? And what do they really mean in terms of when OCD started, how severe the illness is? So are there differences in how comorbidity is present when we're looking at different ages at onset, different ages at presentation, different illness severity, and so on? So it was really interesting. I mean, of course, some of the things were, as expected. So, for example, mood disorders, especially major depression, seems to be the most frequent comorbidity across ages. So, as a pooled, sample of children, adolescents, and adults, if there is one comorbidity that beats all the others in terms of its prevalence, it is mood disorders and especially major depression. But then close enough are, many of the other psychiatric disorders, such as anxiety disorders, neurodevelopmental disorders, OC related disorders, and even the severe mental illnesses like bipolar and psychotic disorders. So what this slide basically shows you is, the black bars are the lifetime prevalence across ages. So these are just pooled samples. The blue bars are comorbidities in adults, and the orange bars are comorbidity prevalences in children. So as you can see in adults, so when we say depression is the commonest comorbidity, mood disorders are the commonest comorbidity, we're largely talking about adults with OCD. Whereas in children, it is anxiety disorders of all kinds, from phobias to generalized anxiety to social anxiety. So it's really anxiety disorders that seem to be, much more predominant. Of course, adults, with OCD very often also have, comorbid personality disorders. One of the really interesting, and if you really think about it, it made sense to us later on, but we expected to see the neurodevelopmental disorders in young people. So we expected to find that ADHD, autism, tic disorders, all the neurodevelopmental disorders are going to be prevalent in young people, not so much in adults and later ages. But to our surprise, we found that neurodevelopmental disorders seem to be prevalent across the lifespan. So irrespective of whether the sample was child, adolescent, or adult, ADHD, tic disorders, and so on, they seem to be present, really throughout the lifespan. And that's what you see, almost equal sized bars for both these disorders. Autism, of course, there's only a bar for children, but I think there are not a lot of studies that have looked for autism symptoms in adults with OCD. But I'm sure if there were more studies, we might find, the prevalence to be comparable, just like for ADHD and tic disorders. And the reason, I guess, that we've discussed in the paper as well is that neurodevelopmental disorders essentially, represent vulnerability right? So the brain is vulnerable to psychopathology, to maladaptive ways of coping, including very obsessive coping. So we find that children who are on the spectrum, or children with ADHD, they sometimes, in conditions of stress, in conditions that are really overwhelming them, they tend to become very obsessive compulsive in their behaviors, right? So the neurodevelopmental disorders, I think they represent baseline vulnerability, on top of which phenomena like obsessions and compulsions can occur. So it is therefore understandable that they could actually be seen throughout the lifespan, because they're going to continue to be a vulnerability, especially when they persist. We know that a large proportion of people who have ADHD in childhood continue to have it as adults. People who are on the spectrum continue to have spectral features as their adults. So because that vulnerability continues, so does the comorbidity that we see across, studies. And of course, there are disorders like ODD, oppositional defiant disorder, which again, it's a diagnosis that you make in children. So in children, it is seen to be prevalent in 12% of the pool sample that we studied. So it's important to sort of understand how comorbidities feature across the lifespan, because then those are the questions that we're going to be asking. So if it's a child or an adolescent coming to us and we feel that the primary diagnosis is OCD, then we're not probably, we may want to pay a little more attention to picking up additional anxiety disorders. We may want to spend time picking up neurodevelopmental disorders. We may not, if we're not really getting it, we may not spend a lot of time trying to understand if there's depression, if there's dysthymia, because we don't expect that to be the major comorbidity there. And again, this this lifespan perspective really helps us, because if you look at this particular slide, and I've made this based on this particular paper in Molecular Psychiatry in 2022. So what this paper found is that if we look at the age of onset of different diagnoses, okay, so autism, neurodevelopmental disorders, severe mental illnesses, so autism, at ADHD on one side, and schizophrenia, mood disorders on the other side, and we put OCD in the center, and we compare, how does the age of onset distribute across, these diagnostic categories. Very interesting. What do we find? We find that autism, ADHD, 50 to 70% of the cases are already picked up before the age of 14, right? And we know that neurodevelopmental disorders should, manifest during the developmental lifespan. Whereas schizophrenia, mood disorders, most of them, the age of onset happens, after 25 years. So early adulthood is when these disorders are most of the time onset. So, but in OCD, what is happening is that before the age of 14, 18 years, 25 years, and so on. So OCD is something that really has, a really wide age of onset. So from very young children, we've had children coming in the preschool age where we picked up OCD. So from the preschool age to early childhood, middle childhood, adolescence, early adulthood, late adulthood, elderly, OCD is something that seems to be occurring at all ages. Unlike these other diagnostic categories that seem to peak quite sharply at the ages that are depicted here. So because OCD is something that can arise at all these different ages, it makes all the more sense for us to really know which comorbidities am I going to be looking for, right? So if an elderly person comes to you, you're not going to be then, you may want to ask for whether there had been spectral features growing up, or ADHD growing up. But what would you be more bothered about? You'd be more bothered about dysthymia and depression in elderly people, right? Whereas in young people, like we discussed, it's anxiety and other things. So that's that's why OCD is so fascinating, because it's seems to have a very, very different sort of presentation across the lifespan, and different ways in which it is associated with comorbidity over this lifespan. So just to sum up certain concepts that one should keep in mind when thinking about comorbidities in OCD. First and foremost, like we said, comorbidities can occur before OCD, with OCD, after OCD. So the timelining of OCD and its comorbidities can be quite variable. They are seen across the lifespan. They tend to vary with age, with gender, as well as with the severity of the illness. For example, very severe OCD, more likely to have depression as a comorbidity. But one can also think of comorbidities in terms of, are there etiopathological relationships? Because this is what I keep telling students, it's one brain, right? So although we like to say that there is OCD and there is bipolarity and there is OC spectrum, but at the end of the day, it's one brain, overlapping circuits that are manifesting in all these, different syndrome profiles. So if one were to think of etiopathological relationships between OCD and its comorbidities, one could think of neurodevelopmental disorders as susceptibilities. One could think of anxiety and depression as either precursors to or consequences of OCD, given the stress, and the emotional toll that a disorder like OCD, especially, because it's so chronic, can take. OC related disorders, one could think of phenomenological overlaps, and which is why they've all been lumped together now in a single broad diagnostic category of OCD and related disorders, because they are so similar phenomenologically, and one wonders if it's the same brain circuit, same biological underpinnings, just manifesting in different ways. Tics have a really interesting, historical etiopathological relationship, if you will, because a few decades ago, there was this developmental basal ganglia syndrome described, right? And people said that there's, something gone amiss within the developmental trajectories of the basal ganglia, as a result of which, what happens? As a result of which, there will be executive dysfunction, there will be motor, manifestations such as tics and, other features. And there will also be a tendency for obsessions and compulsion-like phenomena, right? So it's been described as this developmental basal ganglia syndrome because, they just seem to occur so often, together. So it's almost natural that one might think that they're probably arising through similar brain mechanisms, and that's how the syndrome got defined. But there's one other way of looking at the entire realm of comorbidities, and not just with OCD, but I suppose with any psychiatric presentation that you're looking at, and which is depicted by this particular study from the Nordlots cohort, where they studied 250 young people with OCD, and all of these were young, so these are early teens. The mean age was 13 years. And what they found is that, rather than the response and the long-term course and, outcome of OCD being dependent upon one or the other type of comorbidity, what they found is that they derived like a general psychopathology factor, right? So which means your general tendency to experience psychopathology, to have maladaptive coping, to find it difficult to deal with the stress and so on. So it was the general psychopathology factor which seemed to be shared across diagnosis, and which seemed to be better at a better marker of predicting response to treatment as well as long-term outcomes, right? So of course we want to pick up these categories and comorbidities and so on, but we also want to think in terms of broader transdiagnostic phenotypes and what psychopathology means dimensionally, right? Even within OCD, for example, not every patient with OCD looks the same. There is variation, there is a lot of heterogeneity. So rather than looking at it as purely categories, one may want to look at anxiety as a dimension, obsessionality as a dimension, mood dysregulation as a dimension, and then see what then sort of try to think how a person may respond to treatment or may engage with treatment and so on, right? So I just thought it's important for us to sort of have these concepts in mind when we try to understand comorbidities in the clinic when we work with young people. Of course, the one comorbidity, that stands out from the rest, given its special position in the DSM-5 and ICD-11, is tics. So tic-related OCD is a specific entity that the nosological systems ask us to identify. So tics are prevalent in about 15% people with OCD. Again, this is across age. These are pooled prevalences. It occurs more often in early onset OCD and more common in boys as compared to girls. Some studies report that when there is tic-related OCD, the chances of remission are likely to be higher. Not a finding that's been replicated 100%, but there seems to be some evidence to say that it might be a better form of OCD. It might be more developmentally programmed, and so more likely to remit as development happens over time. So that's again related to the developmental basal ganglia syndrome that we were talking about. But certain other phenomenological characteristics of tic-related OCD are that it often has symmetry related, sensory phenomena related, the not just right type of OCD symptoms. And it also tends to have more neurological soft signs, right? So again, look at the entire, description and the kind of characteristics. It's easy to think of basal ganglia, it's easy to think of development, and it's easy to sort of say that, okay, it makes sense, all of this can exist together, and probably gets better with age, because when we grow up, the brain develops and it overcomes, some of the developmental deficits and delays that may have been manifesting as these symptoms. This again is interesting in the context of tic-related OCD, where the Danish National Tourette Clinic did a 6 years follow-up to see what happens to different types of tic-related presentations. So if there was Tourette syndrome alone, which is your green box, or if there was Tourette syndrome with ADHD, or Tourette syndrome with OCD, or Tourette syndrome with ADHD and OCD. So they were looking at all these different developmental clusters. And what they find is that, there was a whole lot of, cross overlapping and so on. So while some people continued to have, the kind of picture that they presented with at baseline, but a lot of them also shifted category. Of course, the best outcome was, where Tourette syndrome existed alone without, the presence of ADHD or OCD. So again, this, gives us a flavor of the entire, developmental underpinning of Tourette's, ADHD, and OCD, right? So that's how we, are increasingly interested in looking at OCD in terms of its developmental underpinnings. So if one has to, be intelligent about picking up comorbidities, one must be really, really clear with, what the phenomena of obsessions really is, right? How do you differentiate obsessions from other kinds of repetitive cognitive phenomena, such as ruminations, worry, preoccupations, overvalued ideas, and impulses? Because in each of these phenomena, and especially, when you're working with children, the young person is going to say, I get thoughts, I think a lot. And the parents might also just say that, keeps going over the same thing again and again. So the chief complaint, the presenting complaint might be similar, but then what are the features that help us distinguish one from the other? So some of the kind of features that I like to look at when I'm trying to differentiate these from each other. First is the temporal focus, which basically means, what are these thoughts about? Are they about the present? Are they about the past? Are they about the future? Because as you will see, it is obsessions and impulses which generally tend to operate in the present. Whereas other types of repetitive thoughts, ruminations are typically focused on the past or the future, worries are related to the future, preoccupations can really, just be anything. It's just, anything that is going on in the mind again and again. Overvalued ideas, again, gently about the past. But quite characteristically, impulses and obsessions are the ones that operate in the present. It's a thought that I'm getting now. I'm getting a thought about something that I'm currently doing. I'm getting a thought about something that I currently want, that I right now want, right? So obsessions and impulses operate in the present. The second aspect is the content. So the really amazing thing about OCD is that it doesn't matter how old you are. If you have OCD, you're going to wash. You're going to have contamination related thoughts and you're going to wash. So contamination and washing is the most common symptom dimension in OCD across ages, including preschoolers. So even when preschoolers come with OCD, most commonly you're going to see them preoccupied with dirt and germs, and they're going to be telling their mums and dads to wash again and again, or they're going to be asking them to change their clothes, and so on. So if there are if a repetitive thought is obsession, you are most likely to find the typical dimensions of OCD that have been described, right? Which is contamination, symmetry, doubts, aggressive thoughts, sexual obsessions, and so on. Whereas in all of the other repetitive thoughts, you again, the content can be quite stereotypical to that particular phenomena. So ruminations generally be negative thoughts, they'll be about real life events, they'll be about the consequences of these events, and so on. Worries, negative foreboding about future. Preoccupations, thoughts typically related to recent interests. So preoccupations tend to be centered around what a person is really keen on doing or has developed as a new interest, and so on. Overvalued ideas, tend to be culturally or emotionally sanctioned. So, they derive from real life experiences that a person carries forward with themselves. Impulses, again, they will not have, the contamination, symmetry, doubts. So that kind of OCD typical content will not be there. But it will be, again, a sudden, strong, unreflective urge or desire to do something, right? And that something will typically look like an externalizing behavior, so whether it is substance or it is shopping or it is, any other impulsive behavior that one might come across. Then one wants to look at rationality and obsessions and impulses, as well as ruminations. Sometimes, people may acknowledge irrationality, but in obsessions, it is just, of course, given that, person is has insight and is able to is capable of metacognition, which is not something that you may find in very young children. Very young children may not be able to think about their thoughts, so they may find it very hard to sort of analyze the thought and tell you whether it is making sense or not, right? So but children above the age of 8, 9 years and so on, they do acquire the ability to think about their thinking and to have metacognition, and then they can tell you. So if there is insight and if a child is able to think about their thoughts, they will be able to describe the irrationality, and they will be able to say, I don't know why this thought comes. I want this thought to go away. I don't like this thought. This thought is not something that I want to think, and so on, right? So they are able to communicate the irrationality very clearly for obsessions, as compared to these other, differential diagnoses of obsessions. Ego dystonicity, again, very, very high in OCD, in obsessions, as compared to the other phenomena. Insight, interestingly, is variable in obsessions, but in the other repetitive thoughts, in the other, repetitive phenomena, typically insight is present, right? So that is something that, again, makes obsessions stand out. And insight, remember, it's not just, whether it's categorically present or not, but insight can actually vary over time. When they are experiencing a lot of obsessions and they're, stuck with their obsessions, they might say, I just absolutely have to do it. This is a thought that I have to follow. I can't give it up. But at other times, when they are not, in that overwhelming state, they might actually question the thought and say, why do I feel like this? And this is so irrational, and I shouldn't be doing this, and so on, right? So insight is variable even within a person across time. The perceived distress, again, is the highest in obsessions as compared to the other phenomena. And the behavioral response, I think sometimes we don't pay enough attention to this aspect of diagnosing obsessions. If there are compulsions, okay, and most of the times, what do compulsions do? They help a person deal with the anxiety that the obsessions trigger. And sometimes the compulsions can actually be quite unrelated to the thought. So I'm getting sexual thoughts, but I get rid of them by counting backwards, or I'm getting aggressive thoughts, and I get rid of them by, I don't know, canceling images in my mind or so on, right? So the obsessions and the compulsions that they trigger are not logically connected, which is why they're so compulsive, that they're not really, helping tackle whatever the obsessive content of thinking is. So the presence of compulsions is again very often characteristic of OCD rather than any of these other things. In the other phenomena, you may get some reassurance seeking, but most of the time you may actually get acting out. You may get time invested on the area of interest, and so on. But if compulsions are present, you always want to go back and check. Am I missing an obsession? Because it seems to be dealing with it by doing compulsions. Similarly, differentiating compulsions from other repetitive behaviors, right? So there could be stereotypies, mannerisms, tics, impulsive behaviors, and since we're talking about children, childhood rituals. So it's interesting that children normatively have repetitive behaviors, which are developmentally very, very important because they help children to explore the world. They help them to gain a sense of security, comfort, predictability, and so on. So childhood rituals are a developmental normative phenomena, and it is something that typically toddlers and preschoolers will engage in, and by the time that they enter formal schooling, most of them have outgrown their childhood rituals and they won't really last. The content again, will vary across all of these differentials. And in childhood rituals, what will the content look like? It will look like, the child wanting to read the same story before bed, arranging their toys, some other bedtime rituals, and so on, right? So these are all safety seeking, comfort seeking, predictability seeking, repetitive behaviors that young children engage in, which aid their development. So parents must allow these rituals to play out and not, ask the child to give them up too soon. Also, the effective intervention, right, will be ERP is something that works only for obsessions. It's not going to work for stereotypies, mannerisms, tics, and impulsive behaviors, where you need other types of, complex cognitive and behavioral interventions. Of course, childhood rituals, like I was saying, developmental support and scaffolding is needed to, help the child to grow out of them as per their age. Not rush them to grow out of it, but let them take their time. So with that, we know that comorbidities are prevalent. We know that they vary across age. We also know that OCD can, literally start at any age. And so accordingly, we must keep in mind what are the comorbidities that we expect to see. We know that, tic-related OCD especially, has a very special place in terms of its common and shared developmental origins, and how it manifests in young people and tends to have a particular type of symptom profile, and how a lot of them may actually outgrow both the tics as well as the OCD as they grow up. And then if we have to look at comorbidities, we must first make the differentials of obsessions and compulsions very clear. So that's something that we went over. With that, I thought that we could look at some of these comorbidities through case-based examples. And as I do this, I think it would make more sense if we could have some participation from the audience, so that it can be more interactive, and I can actually cater to the kind of questions that you might be struggling with in clinical practice. So to begin with, this is about a 10-year-old boy who reports that he fears making mistakes in math because something bad might happen to his family. Over the last 1 to 2 years, he avoids doing math and has also started having doubts about other subjects. His parents report that since a young age, he has always been on the go. School reports are filled with complaints about restlessness, incomplete work, and talkativeness. So would anybody like to venture a differential diagnosis? What is happening? What do you think this boy's diagnosis might be? And how would you approach it?
So, ma'am, participate in this conversation. So, I think he has this fear of making mistakes. So, magical thinking is there that if he makes mistakes, something might happen to his family. And also, he has some complaints regarding restlessness, and even school reports are there. So, I think the child can be evaluated for ADHD symptoms as well.
Yes, absolutely, Dr. Alapi. So ADHD is something that we, very, very commonly see. If you're sitting in a child psychiatry clinic, in fact, when I was doing my postdoctoral fellowship in OCD, I actually believed that if there is a comorbidity with OCD, it must be either tics or depression, because those were the two common things that I saw working with adults. But in children, we hardly ever see depression as a comorbidity. Tics we do see, but I don't know, somehow it doesn't seem to be that prevalent. But ADHD is something that I see day in and day out, right? So children who come with OCD, always, that there is a background of, the child having struggled with the education, having struggled with, behavioral organization, and so on. And when we, are faced with this presentation of ADHD and OCD, the dictum is, to treat the OCD first, right? Because we know that given the nature of the obsessions, given the distress, and the amount of cognitive space and time that they occupy, they will add on to inattention, restlessness, impulsivity, and so on. So you might, find yourself trying to figure out how severe is the ADHD really, does the ADHD need treatment, and so on. So the first focus in treatment is always OCD, if these two are comorbid. And one does want to spend time in longitudinally assessing the difficulties and taking a more functional analysis of the problem areas. So rather than focusing on that these are the obsessions and these are the compulsions and this is what we're going to do ERP for, versus we will help you organize your routine and timetable and whatever for the ADHD part. It's typically that's a very complicated thing to do, because remember, this is a young person who's already struggling with organizing themselves. And then if the psychiatrist is being very obsessive about matching a particular type of treatment to a particular type of symptom, it just doesn't work. So it's important to have a very functional approach to the presentation. And rather than say I'm going to target your symptoms, you say I'm going to target the areas where you're struggling. So if you're struggling with completing homework, let's do a functional behavioral analysis of what happens when you sit down to do homework. If you're struggling with sitting in your seat in class, let's do a functional behavioral analysis of what happens in class, right? And so on. So and that actually makes more sense to the young person as well as to the family, because that's where they are seeking answers for. How do I make this kid go to school? How do I make sure that they study for their exams, right? So a functional analysis is something that serves the entire situation better. Need for stimulants can always be reviewed once the OCD is relatively treated, and the severity of OCD symptoms has come down. Stimulants can be added to ongoing SRIs for OCD or ongoing CBT for OCD, whichever treatment modality you choose. But one must be a little cautious, given that dopaminergic, noradrenergic pathways can overlap and interact with this hyperserotonergic state that the SRI has put in place. So there may be some anxiety worsening, but most of the time it is something that one can work through with adequate monitoring and paying attention to any emergent features after starting this combination of medication, right? So that's generally a treatment approach that one could take in the presence of ADHD and OCD. Okay, we'll go on to the next one. So this is about a 16-year-old boy who has seen multiple doctors in the past 6 months. And this boy complained of chest pain, and he was very worried about having a heart disease. So he underwent multiple ECGs. He would keep asking doctors and his parents for reassurance. He also did everything in threes, as he thought that it might prevent a heart attack. And V was usually irritable in the last 6 months, and he even stopped going to school or meeting his friends. He was started on escitalopram up to 20 milligrams per day along with CBT in the inpatient setting, given that the irritability and the amount of OCD related problems were quite high. But then what happened? In 2 weeks of treatment, his worries disappeared. He said that the doctors had cured his heart attack. And then over the next few days, he was notably overactive. He talked a lot. He made elaborate plans. His parents found it difficult to get him to do any day-to-day chores, as he kept saying that he has bigger things to do. So anybody has, I mean, there are several things that we can actually learn from this presentation. I would invite anybody from the audience to talk about it.
I think Dr. Vishal Jani has posted something in chat box, and he's saying this is bipolar type 3 plus hypochondriasis. Dr.
Okay.
Akshata also said that it is OCD, hypochondriac, and switch mania.
Okay. Okay. Yeah. So why do we think that there is OCD? I mean, how are we drawing the differential between hypochondriasis and OCD here?
Akshata ma'am is saying that
multiples of threes. Yes, 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 isn't it? And so that's what the thing is. If compulsions will typically be they will be compulsive and they'll have all the features of compulsions, but also somebody with illness anxiety disorder, as hypochondriasis is now called, illness anxiety disorder makes you act out on your areas of anxiety. So if you're anxious about having a heart attack, you'll go to the doctor, you will look at ECGs, you will do that. But this person is not just acting out on the illness anxieties that he has, but he's also doing compulsions, right? Which is sort of the key thing in helping us understand that a lot of this may be part of OCD and maybe actually amenable for ERP forms of treatment, rather than taking more of an illness anxiety approach and so on. And yes, it does look like there was a switch after starting escitalopram, which resulted in perhaps a hypomanic or manic mood state. So bipolar disorder bipolar disorder with OCD, it's really interesting because I'm sure the audience is aware that sometimes obsessions and compulsions seem to fluctuate in severity depending upon which state of bipolarity they're in. Some people say, I mean, there are several articles that say that during depressive episodes, the OC symptoms worsen. During manic episodes, there may even be a temporary remission, of the OC symptoms and so on. But the important thing to know when you're considering this comorbidity in young people is that one has to have a really high index of suspicion, right? Early onset psychopathology of any kind, right? It's we know that when we're working in adult psychiatry, an early onset is generally a poor prognostic factor. So anything that starts in childhood tells you that the brain is more vulnerable, the brain is more likely to have different types of psychopathology. So we must keep a high index of suspicion in young people, especially if there is a family history of mood disorders, if the onset and offset have been really fast, if there has been an abrupt or an acute onset and offset, and some symptom clusters, right? So if the nature of the obsessions is not typical, for example, even in this case, it was not contamination and symmetry that you would typically find in young people with OCD, but it was illness anxiety which had these compulsive responses to it and so on. So it is important to keep a high index of suspicion when you're looking at this group, and especially if you're planning to start an SRI for treatment. What might also help is a longitudinal mood charting, where you're not just looking for sadness and euphoria, but you're also looking for agitation, you're looking for dysphoria, you're looking for excitement. And one must also remember that children tend to have shorter mood cycles. So If you go looking for, does this person have a related mood for a week, you may hardly ever find it, right? But if you ask the parents, is he or she moody? Yes. Does the mood tend to shift quickly? Yes. After how much time does it shift? And they'll say even in a day, it keeps switching, or even in a week, multiple times it switches, from one type to the other. So there are shorter mood cycles. So your typical definitions of hypomania, mania, and depression that we apply to adults may not be, viable when we're looking for mood disorders in children. Also, perhaps, more meaningful to look at behavioral changes rather than, especially again with younger the child. So you want to look at more behavioral manifestations of mood, such as increased psychomotor activity, decreased sleep, and so on, rather than asking them to describe the mood state, which may be difficult, for young people to do. So when we're talking about mood disorders, ruminations, become a phenomenological differential that we have to consider, and we could look at that in the way that we discussed earlier, and anxiety breakdowns, depressive agitations. So there could be these overlapping different mood related, anxiety related phenomena playing out, all of which need to be adequately described. And sometimes I feel that the only way to really understand what is going on with children is to really see things happening over a period of time, right? Because it is very, very hard, especially with preschoolers and early school goers. It is really hard, because they are not going to give you that verbal description that all of our diagnosis, making processes rest upon. So all of our diagnoses require verbal descriptions, right? But with children, the verbal repertoire is limited in terms of emotional vocabulary, in terms of describing different cognitive and feeling states. So the more time you spend, the more number of times you see a child, it becomes more and more clear, and ultimately you will see it, right? So after 3 follow-ups or 4 follow-ups, you will see what kind of phenomena is playing out. The other important thing about bipolarity in OCD is that conceptually, if there is OCD with bipolar, most likely you're looking at a bipolar diathesis. So you must treat it like bipolar disorder. You must aggressively treat the primary pathology of bipolar disorder with antipsychotics, with mood stabilizers, and achieve as much mood stabilization as possible, because that is the goal. And most of the times we do find that if mood is adequately stabilized, the OCD is also much more easy to manage. It is amenable to some CBT based interventions if needed. It's not that SRIs are contraindicated. One could use SRIs, but obviously one would have to do that once substantial mood stabilization has been achieved, and then too under close monitoring and follow-ups, to make sure that activation switch like states do not happen. Okay, we will look at one more case, and which is about a 14-year-old boy who has OCD since the age of 10. He had aggressive obsessions and pathological doubts that responded well to treatment with sertraline and CBT. In the last 1 year, he repeatedly shrugs his shoulders, blinks his eyes, makes grunting noises, finds them embarrassing, but can't help it. And he has started avoiding his friends. Whenever he has to speak to his teachers, these movements and noises increase. So, any guesses? What's going on?
OCD disorder.
Yes. It's quite clear, right? So there are, repetitive motoric phenomena, which the description does sound like tics. So we're back to the tics, which is DSM's and ICD's favorite comorbidity category along with OCD. Now, if you look at what happens to tic severity over age. So remember, tics are a neurodevelopmental disorder. And what do we know about neurodevelopmental disorders? That they will start in the developmental lifespan, and a lot of them will actually reduce in severity with age. In fact, whenever parents come with young children, where the diagnosis is autism or ADHD, and the parents say, "Will my child get better?" I like to say there is no other way. The trajectory of this type of a problem is that it is going to get better. because neurodevelopmental disorders improve with age, right? That they improve as the brain develops. So just like that, tics also most of the times will improve with age. A lot of young people with tics will experience remission as they grow older. So it's important to have that in mind, especially when you're making treatment decisions, right? Because there is a high degree of natural remission, you really want to give medication or even the CBIT type of interventions only where the tics are actually disabling or dysfunctional, or have a self-harming component and so on, right? So treatment has to be very, very specific and chosen only when they're clearly dysfunctional. At other times, helping this young person and the family to look at tics in a more normative fashion, reassuring them about the course and outcome may actually be enough, right? So it's more the social consequences, the shame, the embarrassment, sometimes bullying that the young person has to deal with, because they might individually not really find the tics that disabling to begin with, right? And of course we have to differentiate the urges that a person with tic may experience from the compulsive behaviors. Okay. So I think we just have this one more where this is a 9-year-old boy who's been doing well at school till last year. His father reports that he has always been naughty. He would frequently disobey his parents, would argue, would not accept his fault when caught fighting with his younger brother. The family had let it all go since he was otherwise doing well. Right? This is not an uncommon thing to hear with a lot of the families who present to us, that as long as academics is going fine, as long as the child is active and the child is smart and intelligent, a lot of the problems that could have been picked up early sometimes tend to get ignored. But since a few months, H has started taking more time for a bath, often missing his school bus. His teachers also complained his classwork and homework were becoming increasingly delayed and untidy. He would keep scratching out and rewriting. And when his parents asked him about the complaints, H would become very irritated and he started arguing and saying that they only cared for his younger brother. So, what's going on here? Okay, I think Dr. Vishal has ventured that this is ODD with OCD. Do others agree?
I think sibling rivalry is also there.
Yeah, possibly. Possibly there could be sibling rivalry. But I think some of the
But the
features are.
term naughty is should be considered.
Sorry, Dr. Ramya, I'm not able to catch everything you're saying.
The child is described as naughty also. So should we consider ADHD also here? Because
Yeah,
the
I mean,
homework also he's taking time. It's not in the class also the attention and the scratching behavior, writing is delayed and all that.
yeah. So I think I see the point. I mean, I think it's important to consider whether there are neurodevelopmental issues going on in the background, and which is what is actually adding up to all this reluctance, and with the classwork, homework, and so on. But I think some of the features described here, such as blatant disobedience, argumentativeness, vindictiveness, these are all things that if they are present, one must recognize oppositionality, an oppositional defiant disorder. But I do agree with you, if this child were to present in the clinic, we would want to understand his neurodevelopmental history much better to ensure that these behavioral features that the parents are complaining about are not because of other struggles that this young person might be having. But if we do encounter the typical ODD type of features, again it's important to take a functional approach to treatment. So while we would want to give SRIs for OCD and we would want to do PMT for the oppositional behaviors, but the challenges happen because given that there is a lot of disobedience and argumentativeness and so on, it might be challenging to engage this young person in treatment, in individual work, right? So then it's important for the therapist, for the parents to be open to negotiations, constantly focus on functionality and outcomes, and have a very supportive stance. So we know that this is so this is like, I think, a really good example of the coexistence of internalizing and externalizing behaviors in the same person, right? So there are internalizing presentations, which is the OCD and the anxiety that the OCD must be bringing on, but there is also a lot of externalizing. So where do you exercise behavioral control? Where do you empathize and help this person navigate the anxiety and the repetitive thoughts and so on? So that is the sort of balance that the therapist as well as the parents have to make in a situation like this. The parents also would need a lot of assistance with distinguishing the OCD related anxiety and avoidance from oppositionality. So if such a child were to present to us, I would probably like to suggest admission, so that, not because making a diagnosis is difficult, but doing a functional behavioral analysis in this case, which is according to me, that would be the most important part of the intervention that we do, for us to have a really clear picture of what behavior is telling us, what background story, right? So a functional behavioral analysis is something that we absolutely must do. And based on that, we coach the parents, distinguishing OCD from the oppositionality. And then, we put in the medication, or, the PMT, or whatever it is that we feel is going to work well for this young person. Also, the more time, you spend with the child, and the better rapport you have a much higher likelihood of being able to navigate through the oppositionality that this young person is struggling with. Yeah. So even in other developmental situations such as intellectual disability and autism, OCD can manifest. And in fact, there is increasing research interest in looking at OCD and the repetitive restricted behaviors that one encounters in autism, and trying to understand how they are phenotypically similar and different and so on. So that's an area which has its own exciting bit of research going on. But I just want to, emphasize that in the presence of, these types of neurodevelopmental profiles, one might very often find atypical symptoms. Of course, poor insight is something that's easy to understand. You might also get presentations that may look like pure compulsions. It need not necessarily be pure compulsions, but it might look like that because of the limited verbal repertoire. There may be a lot of acting out on the obsessive thoughts. So if a person is having aggressive thoughts, you may notice a lot of aggressive acting out. If a person is having sexual thoughts, you may notice a lot of sexualized acting out, because those social templates and these inner monitoring and self-regulation is compromised given these neurodevelopmental disorders in the background. So the presentation itself may look very, very odd and atypical. I have seen, this comorbidity very often being diagnosed as psychosis, given the oddity and, the trouble that the young person has with, managing the thoughts internally and so on. A lot of preoccupation with fantasy. And the other thing, in the presence of autism and intellectual disability is that there will very often be symptom migration. So it might not be that a child who began with having OC symptoms related to contamination and washing continues to have them. By the time they come to you 2 weeks later, the obsessionality may have shifted in content, it may have shifted in theme, it may have shifted in situation, and so on. So you might see a lot of symptom migration. In fact, there's this young person that me and a colleague of mine have been working with here. He's now 17 years old. And we worked with him for almost 4 to 5 months. And every week that we would have a session with him, it would to him, it would seem like a completely different problem. And he would actually say, no, that problem is gone. The problem with, my sweaty shoes that my mom wouldn't allow me to leave outside the house, now that is gone. somehow I'm managing it. But this week, the problem is that I can't, I don't know, I can't keep a wet towel, or I can't, do something. So the content as well as the theme, can keep changing, but the core thing, and which is what then, so the work that we finally ended up doing with him is basically helping him identify obsessions. And I think that, basic ingredient alone went a long way in, making him feel more in control. So the moment, then after a while, he became adept at recognizing, okay, this, what I'm telling you, as I'm telling you, I'm realizing that this is obsessive, right? That this is something that's going on in my mind. It's not really that important, but I don't know why I'm not able to overcome it. So I'm going to label it obsession and I'm going to let it go. So because the theme and the symptom and the content and stuff kept changing, it was, challenging to help him make sense. But then finally, when he got the hang of it, so the 4R model where you recognize, relabel, so that itself, went a long way in helping this young person. So in, this background, doing developmental work alongside, family assisted behavioral interventions with or without a combination of SRIs and CBT, so it's that composite treatment that would actually make a difference. There are, extensive books that are available now, including workbooks on working with OCD in people, in autistic people. So that is something that, one could refer to when planning treatment in these groups. Yeah, so I think that was my deck. I'd be happy to take more questions if we have time and people want to ask questions. I think Dr. Sudeep Bhave sir has posted a question. I'll just try and answer that. So, sir, escitalopram, yes, it's not been approved in that sense, but clinically we have been using it. And when do we use it? We especially use it if there is a lot of arousal, anxiety, given that the sedative properties of escitalopram can be helpful in young people. So we have been able to use it. We of course don't use it. So the younger the child, we tend to stick to sertraline and fluoxetine. But with adolescents, I think almost everything other than paroxetine, we end up using. Paroxetine, given its very short half-life and the fact that the activation and if at all suicidal risk with SRIs, all of that can be much more prominent with that short-acting molecule. But other than that, all SRIs have been safely used in adolescents. With preschoolers and young children, if at all we have to use medication, we'd stick to fluoxetine first, and if not, sertraline.
I think there are no more questions in the chat box. So probably, ma'am, you have solved all of us queries through your presentation, and also even you discussed some of the cases. So it was very interesting. I like that taking dimensional approach when you are facing children with comorbid OCD. Also, how to differentiate these obsessions from ruminations, worries, and also compulsions from that stereotypy. Because clinically it is very challenging when very young children with limited verbal capacity, they present to us with this kind of confusing symptomatology. So I think differentiating all these things clinically is very important, and that was the best part of your presentation, ma'am. One more question is there from Dr. Ankita Patel. How is your experience with clonidine in child with OC, ADHD, and some autistic behavior?
Yeah, so see, clonidine, I think it's when do we most of the time like to use clonidine? the typical case would be if there is, a relatively young child who has ADHD. So there's a lot of hyperactivity, there's a lot of impulsivity. Maybe, there is comorbid tics. So young child, ADHD, comorbid tics, that would be like your ideal clinical context where clonidine can be used. When we are treating OCD and you want, some drug to actually help with the hyperactivity, you can add on clonidine, and that's fine. So we have used SSRIs with clonidine where we see this comorbidity. But I think as the child, grows older, so if you're looking at an adolescent, or if you're looking at, 16, 17 years old, a child and so on, where it's not so much the hyperactivity and impulsivity that is troubling you. It is more the inattention, executive dysfunction, difficulty in really sustaining themselves in anything that, they put their minds to. There, I think stimulants, would have a bit of an edge over clonidine in, managing the ADHD symptoms. As far as autism particularly, see, autism, I'm not very convinced that any medication really truly helps. With, I don't know if your idea was to ask about the RRBs in autism or something. So the medication as such to control, RRBs that are otherwise not very troublesome, that are not very dysfunctional. I'm not really sure whether, one would want to medicate that. So we would like to think of clonidine in terms of its ability to suppress hyperactivity and impulsivity. So if you're seeing a lot of that in, the clinical context of OCD, you can, use clonidine. I think there's another question by Dr. Jaya Jacob on habit reversal training. Yeah, so habit reversal training is, something that, is used for any habit like disorders, especially these days. I think there's a lot of literature on the OC spectrum, like trichotillomania and other things. See, the HRT itself, what does it do? It, basically helps a person identify the so-called habits, so you become more and more aware of what are these behaviors that you're doing repeatedly. You become more aware of the urges and the premonitory phenomena, that happen before you do that behavior. And then you literally find an opposite behavior to prevent yourself from pursuing that habit, so you're so the entire focus is on generating this awareness that, look, I can sense that urge is coming, that premonitory sensation is coming, which might make me, take my hands up to my hair and I might pluck. So since I'm now aware that feeling is coming, instead of, taking my hand up, I'm going to engage my hand in an opposite behavior. So that's your competing response, right? So there is awareness and stimulus control, and there is competing response. And the more and more the person practices this, they are, sort of able to deal with the urges by doing the competing response instead of doing the, acting out response. It does work, and it works wonderfully well. But one must keep in mind, and which is why now it's, it's not just about doing HRD, but it is about actually doing comprehensive behavioral interventions. Because we know that most of the times when people engage in these habit-like behaviors, there are multiple factors that are actually sustaining the habit. It could be low mood, it could be interpersonal stress, it could be self-related issues. So unless you comprehensively assess all these maintaining factors, merely doing HRT may or may not work, right? So while the core of HRT stays, it has to be combined with understanding the long-term and immediate maintaining and triggering factors, right? So that's how we would do.
Thank you, ma'am. I think now no more questions are there.
Just one more thing, Isha, like in
Yes, ma'am.
adult life, we see so many schizo obsessive disorders like schizophrenia with obsessions and all. Do we see some psychotic the phenomena in OCD in children along with
Um,
OCD?
yeah, so in children, where we diagnose schizophrenia, there can be obsessive compulsive phenomena. In fact, recently we've been treating child who had, so she's now 12 years old. She had come to us at the age of 10, at which time she had actually come with what we thought at that time were mood symptoms, because she was withdrawn and she was feeling very scared of many different things, and she was very clingy and tearful. So we thought, this is probably a mood disorder in this 10-year-old girl. But within a few months, she actually started to first have obsessive compulsive features. And then soon, within a few weeks, she actually started, very interestingly, she actually started misidentifying her family members and saying that this is somebody who's come to harm her, and so on and so forth. So it is possible that OC symptoms occur as precursors. They can also occur as consequences of, antipsychotic use like olanzapine and clozapine. So it can happen. And very often, again, because young people will have limited metacognition and other abilities, so a lot of times, because the hallucinations may also result in repetitive behaviors, right? So that might look like compulsions. There may be some catatonic phenomena that could also give the presentation of ambivalence or back and forth and so on. So again, the one thing that would help us differentiate is to longitudinally observe and see what is happening with before. I mean, just because there is a repetitive behavior, it may not automatically mean it's compulsive or obsessive in nature. So it is possible, yes, they do occur, but there can be other things that we may have to behaviorally look for, because young people may find it hard to describe.
Right. Great. It was an excellent presentation, Isha, as usually we expect from you. Sorry that I joined late little bit. Just lost the sense of time, but yeah, wonderful. I was almost there from the beginning, just little bit I missed. Yes.
Thank you, ma'am. It's always a pleasure to talk about OCD, and I'm
Yes.
happy that I got to do this, in a program that is organized by you. Thank you all. Thank you very much for having me in this.
Thank you, Dr. Bhave. He also probably joined late if he's there.
Yeah, I'm there. Good evening, Dr. Isha.
Good evening, sir.
I would just like to speak 2 words. I mean, it was a wonderful talk, as always. I've heard Dr. Isha before, and have always been impressed with her erudition and, the wonderful way in which she elaborates. I think in today's lecture, I myself gained much. I mean, it's impressive as to how many facets does a single illness have, so many ramifications that we perhaps rarely think about. And Dr. Isha, you gave much food for thought today. So thanks a lot for that. And thanks.
It's very kind of you, sir. Thank you.
Thanks, Dr. Ratambara, for calling me.
You're always supporting us, sir. Thank you very much. And yeah, Isha, it was really wonderful. All your slides are also very, very, very nicely put and very comprehensive. And as sir
Thank you.
said, that and especially those those 2 slides, maybe even for the youngsters, we have always the recordings also. And I hope that whatever you have presented will be there forever with us. Thank you.
Sure, ma'am. Sure. Okay. Thank you, ma'am. Thank you, sir. Thank you, Dr. Alapi.
Thank you. Good night.
Good night. Bye.
Thank you, ma'am. Good night, everyone.